Hello again, my name is Tony and I'm talking about now the GI bleed video just watched. This was about a young man, Brogan, who said he first noticed problems when he was on vacation with his parents in Hawaii. They were hiking and he noticed that he was getting winded really easily, breathless, which he thought was unusual because he was in good shape, and this basically made enough of an impression on him that he had to make a decision, which was not to mess up his parents' vacation. He didn't want to disappoint them. Kudos, the young man, because it was their 25th anniversary. So he basically sucked it up and didn't say anything. Coming back to the mainland, sometime later, several weeks later, he was getting ready for school and apparently got up and passed out. Woke up. He doesn't really clarify if he fell down and kind of came down to a horizontal position or not, and tried to get up again and passed out again, at which time his roommates called 911. And then he was discovered to have a GI bleed, and the video follows on through that. So the questions are these. Again, the back history, if you want to look at an Ampler type of pattern of questioning, we're looking at events leading up to the call. So the immediate events were a syncopal episode. That's probably how it would have come down on a 911 call. And then if we talk to him, you find out that, oh, what else has happened? And it would be this noticeable breathlessness. So these are the big things. So as a medic, the first things that would stick in mind would be the breathlessness and the syncope and what could cause that. So worst case scenarios would be pulmonary embolism and other obvious cases of syncope. So we take into note what his skin signs were like, try to pick up if there was a change in those skin signs. Had his roommates noticed any differences? Was he having trouble breathing, and in particular his respiratory rate? If he had had pain, that would have been something he'd likely complain about with, like, for example, a small PE. He wasn't complaining of pain, just this passing out and waking up again. So again, back to syncope. Lung sounds would be right up at the top because he complained of breathlessness before. Pulse oximetry would be a factor, of course, and I'd want to get him on capnography because I want to get a really accurate respiratory rate. So clear his lung sounds, make sure there's nothing there, and obviously the rest of his vital signs. Because he passed out, and we're going to assume that his passing out happened with a change of position, it would be worth looking at, do his vital signs change? So we do orthostatics. I don't want him going to standing because he might keel over, so I might go from supine to sitting, see how he does, and then go from sitting to standing with watching what happens, and see if we show signs of loss of preload. And orthostatic vital signs might be a really good way in the pre-hospital world to check for changes in his pulse rate, in his map, if you want to get all technical, an automated BP, or you can do the arithmetic. And something that's not mentioned is what happens to his respiratory rate. And with CAPNO, you could actually tell that really clearly if it was changing. The next thing is going on to his history. We'd look at Ampler again. Does he have any other medical problems? Does he take any medications? And those weren't mentioned in this video. Again, he talks about being healthy. So we're looking at intakes and outputs. If fluid loss is one of my considerations, and a PE isn't likely to be in that factoring because his pulse ox is going to be normal high, then I have to look at where the fluid would be lost. Since he's not bleeding externally, or at least we clear that, then I have to look at other sources of fluid loss. So one is intake output, intake and outputs. Has urination changed? Is he peeing more often or less often? And we, right along with that, we check a blood glucose to see if we have, for example, undiagnosed diabetes, which may be causing also dehydration, weakness, and with that, a perception of fatigue and dyspnea. The next thing I'd look at is, so if he's been peeing a lot more and unexplainably or unexplained urination increase, that kind of points a finger at possible diabetes or something else that affects that, like diabetes insipidus, or a syndrome of, brain farting on the name, but essentially a hormone dysregulation on urine control. If he's peeing a lot less, then we look at, is he taking in less? So we go into intakes. Has he been eating more? Has he been drinking more? Has he felt more thirst than normal? And more thirst than normal kind of points to compensating for fluid loss somewhere else. Now we're looking at another type of output, which is his stools. So we'd ask if he's been vomiting or basically losing fluid through the upper GI tract and vomiting. And if he denies that, we work on down to what has happened with his stools. More stools than normal, diarrhea, watery stools. An obvious cause of dehydration would be, for example, diarrhea. The next thing is ask if he's noticed any changes in his stools. Now, most people, if they see blood in their stools, that'll freak out. They'll freak out and call 911 just for that. If there's fresh blood in the stools, that's most often hemorrhoids, and that would be known as hematochezia, and people will pretty much tell you right up front, I've got bloody stools. The bigger concern is upper GI bleed, where the stool is black and not red, and the reason is if they're bleeding the upper GI tract, the blood becomes digested and it turns black. Patients that don't know this will just maybe not even notice unless you ask them specifically, has there been a change in color? What color are your stools? They'll say brown, yellow, white, whatever, or black. And if the stool color has changed, well, when did you notice that? And by any chance, did you associate that with your, increasing trouble breathing? And are you taking, or were you starting to take any supplements, for example, antacids or iron supplements that might cause you to have dark stools? With that in mind, the next question, so my big vitals that I'd expect to be out of whack would be orthostatics. I'd expect them to be possibly mildly tachycardic and definitely in response to positional change. Respiratory rate would be increased, and lung sound should be unchanged. Skin signs may or may not be factors. He's a white guy, so we'd have to kind of look at his roommates to tell, and we could check conjunctival coloring, for example. And as far as his SpO2, well, the pulse ox only measures the percentage of saturated hemoglobin. So if you had one red blood cell left and it was 100% saturated and the pulse ox could pick that up, it would read us out of 100%. If he was stuffed with red blood cells and 100% of them were saturated, it would do the same thing, read 100%. Normally you get a SAT of approximately 97 to 98%. However, an interesting feature of the oxyhemoglobin dissociation curve is this. When it shifts to the left, or when the person's pH goes up, the oxygen does not disassociate as well from hemoglobin, so that will actually raise your SpO2 reading. Because he's tachypnic, or he's likely to be tachypnic due to the shortness of breath, that can actually cause essentially a form of respiratory alkalosis, and that would actually shift his curve to the left. And so his SpO2 and SaO2 might actually be higher than you would expect, higher than normal, in fact. And in ATLS and in findings on GI bleeds, one of the first things they noticed was that saturation went up on these bleeds as the respiratory rate went up. However, when it came to the volume or amount of oxygen in their system, using the formula of FiO2, which we'd use room air, times the number of the amount of oxygen carried by each gram of hemoglobin, which is 1.34 milliliters per gram of hemoglobin, times their hematocrit, or their hemoglobin level, which in the case of hemorrhage is going to be low, our actual oxygen content will be low. So he is actually hypoxemic at the tissue level. He probably has a drop in his PaO2, which is the amount of oxygen dissolved in the blood, but his saturation is perfectly fine, just not enough buses, so to speak, to carry oxygen. So fluid is going to be the treatment, especially in the short term, because he's probably, or he may be well dehydrated, as he mentioned. And I would bet you if the hospital found out he was dehydrated, it would have been through checking his urine output or a specific gravity in his urine test. So fluids would be a good start, and supplemental oxygen if he was symptomatic at all. I would want to give fluids, but I'd obviously not blow it out. I'd start with just enough to get him better because I want to hemodilute him. And wherever he's bleeding from internally, I don't want to accelerate that bleeding. And supplemental oxygen, if there's any signs of distress in any other feature, I would give him that. And in fact, you could monitor his breathing and respiratory rate to see if he improved with supplemental oxygen. So that concludes the assessment for the GI bleed.